Today about topic we all we need it in our research, because we are academics, so eventually we have to do research. So this is the just basic introduction to the types of epidemiological research or studies. Type of study designs, we divided those into two main groups, either interventional, we do intervention, or observational. Observational, we don't do intervention. Observational is easier, it's quicker, it's cheaper, but it has lower quality in general. Interventional, we need to have intervention. Either we give medicine, we do counseling, we do lecturing, we do anything. We have to do something. So we call it interventional. We can deal with the human as intervention study, or we deal with animal studies, or lab-based. It depends on the intervention. So we classify those, the experimental one or interventional one, either controlled or uncontrolled. The control one, we have to have the control group always, which is higher quality, because we need to compare the test group outcome against the control group outcome, because there are so many factors influencing the outcome. If we have only the test group, we may have something like legislation going on, or history, like something political could affect the outcome. Like the government say, we will apply the health insurance in Iraq now. So every single one will have health insurance. So there is no, we did nothing, but there is outside, intervention affect the outcome. So if we have to have control group to say, if this, the intervention external will affect both, and control group and test group. Very good question. Thank you so much, Dr. Ali. If there is an external intervention, we call it quasi-experiment. I didn't mention it here. They call it quasi-experiment. It's not our intervention. Like, for example, now the dean decided we need to apply the clicker. We need to measure the effect of the clickers on the outcome, which is the student learning, student understanding. So we need to have measurement before the clicker implementation and after clicker implementation. We didn't do the intervention, but there is an intervention somewhere. This is called quasi-experimental because it's natural. They call it natural experiment. Or the government decide to have the health insurance. We need to measure before health insurance, after health insurance. We didn't do the intervention. It's a good question, but there is an intervention. It's like natural one. From the government, from outside, from somewhere. So we need to know there is an intervention. We can measure it, but it's not ours. Okay? We cannot control it. I think this one will be more generalizable, because we always talk about, do you know the difference between effectiveness and efficacy? The effectiveness is more generalizable. It's in daily life. It's efficacy, but in daily life. While the efficacy, it's in an ideal world. The randomized controlled trial, it's an ideal world. It's not real, because we pay to the volunteer to participate. We have all the resources for this experiment. So it's an ideal world. It's not like natural or daily life world. So effectiveness, we need to measure this outcome in daily life, like in medical city hospital. We need to go to daily life. While in randomized control trial, we have very well-trained staff. We have good funded experiment. We pay for the volunteer, but in daily life, we don't pay for the patient. It's natural. So we may have so many missing data, drop out, all those. So effectiveness, we need always to have generalizable. Observational study, as I say, either cohort study, which is either retrospective, or prospective. Cohort is chunk of people. Case control study, we have to have a patient with disease, patient without disease. For example, if you need to measure the lung cancer, you have to have patient with lung cancer, patient without lung cancer. For example, their relative. When they come to the hospital, patient with lung cancer, their relative without lung cancer. This is a case control study. Case control study, it's also retrospective. Cross-sectional, we know the survey, we know the interviews, all those calls. Cross-sectional, we need to take snapshot. So the same thing here. In the United States and in the developed country in general, they have something called secondary data. The good things about electronic health record, everything is there. We can have so many data in this device, in the computer. So like in my PhD research, I did primary data collection. It's natural for Iraqis to go by themselves to collect their data. But other colleagues, they prefer secondary data because we have something called Medicare, which is for the elderly above 65 in the US. They have the data for example, for 15 million seniors or elderly people. So they have the data there. I cannot say everything there, but at least they have all their follow-up, all the information, patient history. So you don't have to go by yourself to collect the data from force setting. You have so many limitations. You have limitation in your transportation. You have limitation in your resources. You cannot now, if you want to have a research in Baghdad, you cannot do research for every single hospital in Baghdad because you have limitation in the resources, in the transportation, you have in your access, in your networking. But if you have all this data in your computer, but also the secondary data has its limitation. Why? Because doesn't have its. You need to deal with it as it is. You cannot change it. Like if you are planning to know some specific criteria and this criteria is not there, you cannot add it. You need to change your proposal according to the information available. So you need to customize your proposal according to your data. It's not the opposite. But while on the prospective study or any study, primary data, you can put your proposal, you can put everything you want because you are going to measure those. But in the secondary data, when I took secondary like registry, so that's why we need to educate Iraqi Minister of Health and other colleagues. We need to have a campaign about implementation or necessity of implementation of electronic health record. All these we already mentioned. In general, we have two types of studies, either descriptive study or analytical study. Descriptive doesn't have, there is no data. We usually, or there is data but doesn't rely on the research. I need to describe College of Pharmacy, how many lecturer, how many professor, how many staff. It's just descriptive article. But if I need to study something, I have to have one of the analytical studies. So descriptive studies, we usually just describe. Like I published an article in American Journal of Hospital Pharmacy about pharmacy in Iraq in 2013. It's just descriptive. I just mentioned how is the Iraqi pharmacy profession, how many College of Pharmacy, the history of Iraqi pharmacy, just descriptive. I didn't do research. I didn't test something. I just talked about Iraqi pharmacy. I brought some numbers, but I didn't test something. Yeah. It could have descriptive. It could. You could have descriptive, but there is no test. Just descriptive. Yeah. Yeah. It could be a review, but there is no test. When I say test, analytical study, I have to have. We have to have hypothesis. You know, in the United States, in my department, when you talk about a study, you have to have hypothesis. Hypothesis is required always because the hypothesis is your research question. We call it research question, but they call it hypothesis. You have to have something like there is significant relationship between the age and hypertension. This is my hypothesis. Either I reject the hypothesis or fail to reject. By statistic, we cannot say accept. You say fail to reject. So so there is hypothesis. There is research question. You have to have a question. You cannot manipulate your question after you did the study. You have to have the hypothesis before you start. You cannot manipulate it after. Like in some of our colleagues, we may do the back and forth. We did the research and we see, but the ideal, you have to put your hypothesis first, then you work to test the hypothesis, either reject it or fail to reject. So types of studies in population: correlational, ecological. Have you heard about ecological study? Ecological study is a broad term. It's deal with the pyramid. It deal with the human individual factors. It deals with the inter-individual factors, relationship between persons. It deals with the community and the society. For example, if we need to do research about students, we need to do first take their student characteristic first, inter-student relationship between among students, then the organization factor, which is the college, then the community factor, then the society, like the hierarchy. So this is called ecological. We need to take from the individual, we go up to the society. Like for example, the smoking. Smoking, we need to take care, we need to measure, we need to measure the patient or the smoker factors. Relationship of smokers with their family and their community, if they work like in the industrial area, this is called community. Then with the society, about the government, now in the US and Western country, they apply taxes, like very high taxes to prevent smoking. Like for the one pack of cigarettes, they have like 3 times the price of the pack to discourage people from smoking. Imagine, this is the policy of the government. They don't allow them to smoke in the public area. They don't allow them to smoke in the buses or in the university campus. So it's society. There is a society. There are society factors influencing our individual behavior. So we need ecological. It's broader than single person. Case report. It's just one like single or several cases. Case series, we have several cases. Analytical, epidemiological. We always to have test causal hypothesis. As I mentioned, we always have to have hypothesis before we start our project. It's a requirement for the proposal. We hopefully in our department to mention your hypothesis. Before you start, I need to measure the relationship between the age and the hypertension. My hypothesis, there is a significant relationship between the age and the hypertension. Either I reject it or fail to reject it at the end. This is your main objective. Observational, non-experimental, it's either, as I mentioned, cross-sectional. Now, in our department, we know about the survey. Also, there is another thing. Survey usually collects something called, we call it quantitative data. But there is something called interviews. Interviews or focus groups, we collect qualitative data. What do you mean by qualitative data? We don't have numbers, but we have quotes, we have statements. I ask the students with open-ended questions, what do you think about your study in the winter? They will give so many comments. So there is no number, but there are so many comments. We can take those, transcribe them, and choose quotes from those, and put it, we call it qualitative. And also, qualitative data. The good question, Dr. Qualitative data, we don't have to have large number. Qualitative data, you can have. I was one of the participants in the PhD thesis in the University of Iowa. There was a Turkish PhD student. Her study was about qualitative interviews. She took only 5 participants. In PhD thesis, only 5 participants. And she did interviews with us. I was one of them. And finally, she analyzed our results. And she put many pages about 5 people because I remember like 3 hours interviews with me. And she wrote every single, and she reported, like audio recorded the interviews. Eventually, she transcribed it and she put all the results. This is called qualitative. We have to have something, if I have time maybe in the next seminar, we'll talk about mixed method. Mixed method, we can have survey plus interview. Like we do survey with people and we do interview with them, either interview first, it depends on the explanatory or exploratory. Either you don't have an idea about the survey. How can you write the survey if you don't have the idea? You need to do interview first and write everything, single detail. Then you construct your survey. This is called mixed method. It's very important now. It's very common and very strong. So case control usually retrospective. You have disease, you have the control group. As I mentioned, disease could be lung cancer. Control group should be free of the disease. The same risk factor we usually, those patient care. Cohort study, either retrospective or prospective. Which one is more expensive? We need more resources for the prospective one. We have to follow up the patient. For example, one prospective study in the University of Iowa College of Public Health will talk about the pesticide effect on the farmers. They follow up those farmers for 30 years. It was prospective studies. They try to see the effect of pesticide on the cancer. Imagine you set a time and follow up those farmers until they die, like for 30 years. Imagine how much money you need to put and resources to have this. But in the retrospective, it's much easier. You go to their medical record and just review it in one or couple days or a week or whatever, and you find all the information there. You don't have to spend money and travel to see them and follow up with them. This is the idea of retrospective, prospective. In general now, all studies like the retrospective, even it's lower quality, but it's much easier and time consuming for a prospective one. So you cannot compare the time, especially in our, like now in our study, the diploma, high diploma student, we just talk about them. They don't have time. You cannot say, you need to put them frame time, not more than 3 months. So this is the limitation. Interventional studies, either clinical trials or maybe animal trials. This is the pyramid. I think it's an important one. If you can see the top of the pyramid, it's the highest quality. What do you mean by highest quality? Highest quality studies. If you send this to the journals, they will accept it. Which one is the highest quality? Something called systematic review. What do you mean by systematic review? Do you have an idea here? It's a review article. But this is meta-analysis. Meta-analysis is the highest quality. Also, the systematic review is the highest quality. Systematic means if Dr. Dia did this systematic review, I can do the same review after him. He will give me all the keywords he used in his review. Then I can use the same keywords to find the same findings or results. It's a repetition. So why call it systematic? We will able to duplicate the study or the review. So it will give me the research engine, the keywords. I can use the same keywords and go to the PubMed or the same Google Scholar or whatever research engine and find the same findings. So this is the systematic. While the narrative review, I can do narrative review. There is no restriction, but Dr. Dia cannot repeat it after me because I did it in my searching way. I looked to the references, I looked to the Google Scholar a little bit, I went to the PubMed, I went to Sinhol, there is no systematic way. He cannot repeat it after me. So systematic review, the top quality is meta-analysis. Review article don't have to be, there is a data, you just report someone else. But in meta-analysis, you have to summarize or compile the data and do certain analysis, which is the highest quality, meta-analysis. Randomized controlled trial also on the top. Non-randomized goes now down. Observational studies, now it's fourth. This is the highest quality in the top, lowest quality in the bottom. Case series, case report, and finally expert or opinion. If you need to have a good reference, you cannot depend on the expert or the opinion, because there's no research. It's just an idea. It's my idea. I'm expert. I know I'm expert, but I could be biased because I have my own idea. You cannot argue with me. It's my own idea. It's opinion. But if there is a research, you can argue with me. So in general, we have, in general, as I mentioned before, we have experimental, we have observational. The best method, we always look for the randomization. Randomization, I know it's difficult. We have to have the list of the participants before we randomize them, or we need, because why we care about randomization? Why do you think we need to have randomization? To avoid which kind of bias? Which kind of bias? First of all, selection bias. For example, if I choose this student for the test group and the other student for the control group, at the end of the day, I will have good results for the test group, and I will say, look, a test group, it's really worked, but I already selected this good student for the test group, and I got better results. So this is my selection bias. But if I had randomization, I didn't choose it. Also, it will take care of all the, we don't have to do matching. What do you mean by matching? We don't have to say, I have to have 5 females in the control group, 5 men in the test group. If I do randomization, I could have some limitation, but at least the characteristic, demographic, the age, the gender, randomization should take care of all these limitations. I will say I did randomization, I got those 2 groups. So it will also control the difference in demographics between the control group and the intervention group. For the observational, we always have these limitations. But even in the observational study, we can do randomization. Like if for the observation study, I will say, I will choose, I will have list of 100 pharmacies in Iraq, in Baghdad, for example. I will do randomization. I will choose the third one from each list. I will do this way. Or I will say, I will put them in the jar. I will pick one of them. This is randomization. That's it. We don't have to have very complicated computer randomization. We can go this if we have a clinical randomized trial. But we can do simple way of randomization. We choose every second one. We take the second, the fourth, the sixth, the eighth. This is randomization. So randomization always will have better quality of research and finding. We will take care of the selection bias and will take care of the choosing the demographic data. Interventional studies, which one is the highest quality of the interventional studies? One with randomized, we call it randomized, controlled, blinded trials. What do you mean by blinded? This is the highest quality. We call it double blinded. I'm not sure if I have this one. We call it double blinded. This is the best, higher quality. Why? Neither the participant nor the researcher know which is this patient within the test group or control group. Why we do this? To avoid what? To avoid the bias, the selection bias first. This is from research point of view. For example, if I don't know which one, because if I need to do a randomized control trial, I have to follow up with both groups. I need to have the same behavior with them. I don't want to change my behavior. If I know this is the test group, this is control group, I will behave differently. I will treat this better because I need my outcome to be better. So I will be biased. But if I don't know them, I will treat them equally and see what's the results. From the patient point of view, there is an adherence. If you say, if this patient knows this pill is a placebo, for example, do you think they will take it? No. So, but if if they don't know this is the placebo, they will take it because they don't know if this is medicine, real medicine, or just sugar pill. Imagine this is 2 point of view. So let's talk about the highest quality, randomized, controlled. We have randomization, we have control, blindness, clinical trials. The lower quality one, randomized but blindness not achieved. We cannot say blinding. We say clinical, randomized, control trial, but it's not blinding. Some studies we cannot do blindness. For example, if I need to have interventional test or interventional clinical trial, like in the University of Iowa, they have pharmacists educate patients about taking care of their blood pressure. One group, I will educate them. The other group, I will not educate them. So I cannot blind them because they know I already educate them. This is the intervention group. I cannot achieve blindness in this case. So we cannot achieve blindness in some cases. It could be single blindness, like that. They always do. The researcher is not to prefer you as I'm talking about the clinical trials registered in the FDA, because FDA always need those, phase 3 and phase 4. That the companies, pharmaceutical companies, they need to have the patient clinical trial about the safety and effectiveness of medications. So always we have to have a participant. They always in clinical trials try to bring third-party biostatistician to report the data. They don't like the researcher themselves to report it, to avoid manipulation of the data, falsifications, all those, manipulation in the data. So there's always third party. It's better to have third party to report your results. But in the interventional study, you cannot do blindness. The lower quality, non-randomized, like, for example, if it's sometimes there is a randomization, but not on the individual level. This is other point I need to remind you about. We can do randomization at the setting level. Like, for example, in medical city complex, Baghdad Hospital, it will be my intervention group. While the surgical hospital, it will be my control group. So this is not randomization. It could be all the setting will be intervention, because there's something in the control trial, we call it contamination. I don't want to control group, tell the intervention group, tell me if I have non-randomization. We can do randomization at the setting group. If it's more than one setting, we call it multi-center or multi-cluster. Randomized but deficiency in execution, analysis, non-randomized. The good things, if you need to do good research, you have to plan your analysis at the beginning. You need to know which type of analysis are you going to do. You cannot do this later. It's better, higher quality, to decide your analysis before you start your project or your study. It's always the highest quality to decide. So in general, randomized control trial, we have one group. We did the randomization. We have two groups now, treatment group, control group. We give them the medicine or the intervention. We follow up them 3 months, 6 months, 9 months, or 1 year. It's up to the study. So at the end, we have to compare the outcome of the control group with the outcome of the test group. So randomization benefit, as I already mentioned, we need our groups to be comparable. The control group and test group, we have to be comparable. I cannot say all the male in one group and only female in one group, because it will not be generalizable. I cannot say this group is a very elderly group and this one is a younger group. Those are non-comparable groups. I will have some bias. It's better to have randomization. Some type of randomization, I can put like quota or something for the gender. In my control group, I can choose 5% male at least, or 5 of men, something like that. So I can decide. A blindness, always higher quality. either single blindness or, as Dr. and Dr. I say, double blindness, which is the highest quality. Blindness, it's not easy. We cannot apply this to all types of studies, interventional studies, behavioral intervention. We already know the control group and the test group. When I talk about the studies, I need to know the time of those studies. For example, if I say prospective, when I say prospective study, I say it's in the future. Because I will start now, I will follow up those people in the future. This is prospective, okay? As we mentioned, it's expensive, time-consuming, we need so many resources, it's not easy to do it, but it's higher quality. I can choose whatever variable or parameter I want to measure. I put it in my study because I will measure it. I will not look to something limited in the past. I will not look to someone else. Like I asked one of the doctor in the medical city, I say, how can I do retrospective chart review, retrospective chart review? He said, you cannot do it. I say, why? He said, because you cannot find all the data you are looking for in the charts. There are so many missing data in the charts. You cannot rely on those charts. You have to have a perspective, so you can collect whatever you want. Retrospective, it's easier, less expensive. It has own limitations. I have to deal with the data available there. I cannot bring additional data. Case control, it's also in the past. Cross-sectional, it's in the present. The weakness in the case in the cross-sectional, I cannot prove the causality because I didn't follow up patient. So I cannot say this smoking exposure led to lung cancer because I didn't follow up them. I just took this snapshot as now, taking this picture for you guys, just this. I cannot say which one caused the outcome. Longitudinal, in future, control trial in the future. For the epidemiological study, they have two terms called prevalence, incidence. You know the prevalence, all the cases. Incidence is only the new cases. The causality, we have to have prognosis. If you are looking for prevalence, you need to have cross-sectional. You're looking for incidence, you have to have cohort, case, all those outcomes. It depends on your outcome. In general, observational cross-sectional one, you can find people, exposed people, non-exposed people, people with disease, people without disease. For example, smoker people, non-smoker people, people with lung cancer, people without lung cancer. This is the cross-sectional. You can find all those people. This is the simple way to remember the case control. Case control, it's usually looking in the past. But you only find this patient with lung cancer, this patient without lung cancer. And after you know those cases, they call it case control, you look for their past. You look for their history. Did they exposed to smoking, radiation, whatever? So we are looking for the disease first, then we look for the history. This is the case control. As you can see, exposure is question mark. You don't know their exposure. You only know this is the lung cancer patient, this is the healthy patient. For the prospective study, it's good. Prospective, I know this is smoker, this is non-smoker, but they don't develop the disease yet. I will follow up them to the future. Which one going to have the disease? So this is, I know only the exposure. For the retrospective study, I also know I know the exposure. For example, I'm looking for the area exposed to depleted uranium radiation. I know this is the area, but I have no idea about the disease, how many patients have the lung cancer. So I will choose the Tuatha, for example, exposed to the depleted uranium. I will look for their medical chart to find which one developed lung cancer, which one is not. So this is the idea. You know the exposure, but you don't know the disease. You are sitting here. The other example, I think, this one is just repeated. Cohort and case control study. Even the observation study, we said observation study is less quality than the intervention, but it still has value, you know? And so many manuscripts published there. And the social science and the observation, we can improve our observational study quality. How can we improve them? We need to have the hypothesis, our research questions up front. We need to have to decide the analysis before we start. Like I need to measure the relationship between the lung cancer and the smoking. Which kind of analysis? Whatever, like regression analysis. I will have multiple linear regression analysis to measure all the independent factors of this patient on the outcome, which is the disease. Hypothesis, so this is the highest quality to lower quality. After, if you do the hypothesis later, it's lower quality. If you decide the analysis later, it's lower quality. Can you see? There are measures like in the quality. Hypothesis specified prior to analysis of the problem. Nature of prospective study. As I mentioned, in the prospective studies, we have two groups of patients, and then we will divide them and we'll follow up them in the future. Some outcome variable could be mortality, especially in the oncology center. They usually do the mortality as the outcome because the patient eventually will die, like the metastatic cancer. They usually die. So in these cases, we'll have the outcome will be the mortality, and we will have different kind. They call it survival analysis, which is more complicated to explain here. But it's kind of analysis we need to follow if we have the mortality. So basically, cohort study, we have exposed and exposed to smoking, exposed to depleted uranium, exposed to radiation, exposed to whatever. Eventually, we need to follow up them, either develop disease or not develop disease. Either we follow up them in the past, if we have good charts, or follow up them in the future. Okay? Nature of prospective, I think we mentioned this. It's time consuming. We need so many resources. But it's better quality. We can decide which parameters we are going to measure. So it's a pros against cons. If you need something, if you need to measure something new, you have to choose prospective. If you are, say, I don't have time, I don't have resources. My PhD study, I did retrospective chart review because I looked for 1 year before my visit. I didn't have 1 year to collect the data. So I just went to the charts. I looked 1 year back. It was enough for me. So it had limitation. So in general, design of cohort study, same idea. We usually, in the cohort study, for the non-randomized, we have to have exposed, non-exposed. This is for all the epidemiological studies. Like there's an epidemiology department in College of Public Health. All their research related to the exposure and the disease. They are looking for which exposure caused which disease. Imagine you're always looking for exposure and looking for disease. This is the study, one of my instructor in the epidemiology department. He was looking for pesticide in the North Carolina and Iowa states, looking for those patients taking using those pesticides in their farms, and follow up them in the future. They recruited around 89,000 enrolled in this, and they follow up them for 30 years. Imagine the grants, the money they need to follow up this large number of participants. So prospective, you are here, and you know this is the obese person, this is the regular person, follow up them in the future. It seems like a perfect study, but you have to have always enough time, enough resources. Nature of retrospective. Retrospective could be, we always prefer this if we don't have resources. So what's the difference between retro and prospective? For example, in the prospective study, you are in 2008. Imagine we are in 2008. We need to measure this patient in 2018 and 28 in the future. But in the retrospective, if we are in 2008, we only look for back 20 years. This is the difference. So this is also same idea of retrospective, going back in the past. Nature of retrospective, and this is I think this is the conclusion. The investigators now, they are not comparing prospective against retrospective because they know they only compare retrospective cohort against case control. They only choose between two of those retrospective studies because it's like dominant decision. Retrospectives are much more affordable, so they always choose either case control or cohort, retrospective cohort. Now they try to say prospectives, don't think about it. So case controls, what the difference between case control and retrospective? Do you know the difference between case control and retrospective? In the design. You can look to the design and see. Case control, we are looking for what? First, case control. Disease control, healthy. What about retrospective cohort? Looking for what? We are not looking for the disease. We are looking for the exposure. Exposed, not exposed. Retrospective, we need to know if this is smoker, non-smoker. And then see if this developed to lung cancer or respiratory disease. While in the case control, we are looking for the lung cancer first, then see if this is exposed to smoking. Is the opposite. Either looking for the disease or for the exposure. For the case control, we are looking for the disease, then explore the exposure. It's the same, but it's different in the design. Because it's easier for you if you are in the oncology clinic to decide this is lung cancer patient, this is healthy patient. It's easier. I think they are equal because both retrospective. But depends on your objective. It's which easier. But for the other study, you know this area exposed to depleted uranium, for example. It's now you know the exposure. Then follow up with the disease. This is the different. This is the relative risk. We also measure the relative risk of the exposed group above the normal group or non-exposed group. This is other calculations. Relative risk. It's usually measure if it's more than one. That means this exposure is risky. For example, if this smoker has more than one, the relative risk means smoking will cause the disease. If it's less than one, this is protective exposure. For example, the vaccination. I can't see the exposure to vaccination. Vaccination should reduce the relative risk less than one. That means this vaccination or immunization help me to protect me from the disease. So it could be less than one, could be above one. One means no difference. No difference. It's similar to the AIDS ratio. AIDS ratio more than one, there is a positive relationship. Less than one, negative relationship. One, there is no relationship. Sources of data, it depends on your field. In our field, in the clinical, we have to have the charts, patient, medical, or the physician. When I look to the charts in the nursing homes, I look for the physician prescribing, pharmacist notes, nursing notes, hospital discharge information. They have huge data there. So for the lab section, you can look for all the lab. I looked for the lab information for 1 year before. All the lab tests, I had all the lab tests for those patients for 1 year. All those lab tests already there. So I went, I reviewed them. We call them chart extraction or medical record review. Same thing. Chart extraction, it's skills. You have to have enough training and skills. You can review those and identify any outcome. So the comparison group could be internal, could be external. For example, the comparison group or control group in case of lung cancer, it could be their relative, comes with them. Or it could be external, anyone who lives in the same neighborhood. For example, in the Tuweta or other ones, anyone, it's external. You don't have to be relative. It could be external one, or it could be internal. So control group, you need to know which, salam alaikum, which it depends. We always to have, you know, in the United States or in the Western country, there is no free participation. You have to have incentive. You need to pay the participant some incentive, money or whatever, so they can come and participate. I participated in couple research. They paid me like the bus fees. They gave me some like $5 or 10. You know, for students, they pay something like small. But you have to have, because you are going there, you spend an hour from your time, it's not free. So you always to have to mention if you offer incentive to your student, to your participant, and they don't like the participant from your students because they imagine you have the power, you enforce them to participate. This is the ethical issue if you enforce your student to participate. They have all the issue of the ethical ones, and they're called IRB committee. Selection of comparison, either external group, as I mentioned, in the neighborhood, or internal group. It's the same family. The same family. This one is a smoker, this one is not smoker. And this one developed lung cancer, this one didn't develop lung cancer. So it depends on the disease and on your sample size. Issue in the analysis and interpretation, follow-up study subjects. The main limitation of interventional study or clinical trial studies or any prospective study is missing data. If this patient drop out, if this patient give up and you didn't have, you were not able to follow up them, if you lose contact with them, you will have missing data. This will impact negatively on your results. So imagine the best thing you do your best to follow up patient, because we don't like missing data. If we have missing data, some idea they say you can replace them with the mean. Or you can put, like for example, you need to follow up this patient every month. And you have missing data in month 3. You can replace it for the average of month 4 and month 2, take the average and put it in the, but always we have this, you know, speculation. We don't have accurate data. So the worst thing you can do for in your study is if you miss data or miss subjects or miss participants, because it will affect your results. So this is the kind of summary. If we are looking for the information, which one is better, retrospective or prospective? Which one is complete information, retrospective or prospective? Prospective will be complete information. Retrospective, you are limited what's written there. You are reviewing what's written there. You cannot bring something new, because this one is written 1 year or 10 years ago. You cannot add something new. Discontinuing exposure, prospective or which one is higher risk about discontinuation? Prospective or retrospective? Prospective is at high risk because you will lose the exposure. Something happened and this patient is not exposed to smoking, quit smoking. While in the retrospective, if this patient already exposed to smoking 20 years. But in the prospective, this patient quit smoking. So this patient lost the exposure. Emerging new exposure, which one is more useful? Prospective, why? Because in the future, you can measure the effect of the new policy, effect of the changing in the governmental regulations. While in the past, you are dealing with the fixed data. Which one? What about the expenses or resources? Which one is more expensive? Prospective. Why? We have to follow up We have to attend and follow up and take measures. Completion time, which one is shorter? Retrospective. So keeping those in mind when you are designing your study. Analytic observation strength of cohort study. You need to have the all those are like particular strength if we deal with the exposure. We have so many details. It's not our topic in the epidemiology, but in general, you need to know which type of exposure, the time of exposure, the intensity of exposure, all those affected your outcome. You need, like for example, for smoking, you have to have the number of pack per day, duration of smoking, the year of smoking, because we need to have all this information to compare in a fair way between participants. مو انت مثلا if you have those two smokers people, you cannot say that this patient has the same exposure to the other one. This patient is a smoker for 25 years, 2 packs per day, while the other one only 5 years smokers and 1 pack per day. You need to measure the intensity and the duration. So you will say this is with higher exposure, this one with moderate exposure, this one with mild exposure. Heavy smoker, moderate smoker, mild smoker. This is just example about any exposure. So it depends on the exposure. This patient may have maybe smoker working in the oil company and also living in area with depleted uranium radiation. Imagine. So I have like multiple risk factor. So we need to take this in our account if we need to follow up with the exposure. Thank you so much. I think I'm done for today. I'm happy to receive any question, to answer your questions about, just summarizing, we talked about the, for those who just joined us late, we'll do this summarization, quick one, for the main idea of the study. This one, just, okay. We just talked about, we have 2 types of intervention, either. Go ahead. Simplest method, ممكن تحصل لستة للمشاركين وتاخذ مثلا every أرقام الفردية, every third one, every fourth one, هاي simplest one. هو حقيقة برا اكو فد طريقة بالراندومايزيشن تضمن الكواليتي بالجندر. اي اكو طريقة بس شوي معقدة يعني. انت طريقة مال الكولوم يعني مثلا يعني الراندومايزيشن ما تسوي كل الجروب. شو نسوي هسه؟ هسه اسوي راندومايزيشن الجروب 4 people. يعني سوي راندومايزيشن 4 people وعلى اساسه تبني يعني مثلا اول 4 شفت 2 men و 2 women لا تغير وراها تسوي بعكس التيست جروب حتختار تفتهم شنو ممكن تسوي على هذا الاساس بس يبقى راندومايزيشن ممكن تسويها هم برا ما يختارون راندومايزيشن كل الجروبات هم طبعا مثلنا يعني عندهم ليميتد ريسورسز يعني كلينيكال ترايل فيز 2 فيز 3 انت لا تتصورها هي كلش اكسبنسيف يعني البيشنت واحد ايش قد يدفعوا له البارتيسيبنت من سمي بيشنت وايش قد يراد له فلوس فشو يسوون؟ مو راسا يقسم يعني اجوهم 2 patients واحد راح يذبوا بالجروب يعني شويه الجروبات يترسوها مو راسا عندهم هم 100 واحد واقفين بالباب وراسا انتم كلكم تيست جروب انتم ماكو شيء هم يعني مثل ناقوط الحب على قولتهم شويه وين ما يجي البيشنت فهناك يقدرون يسوون كنترول جود كويشن دكتور ضياء على مود الجندر. هاي بعد كمبيوترايز. ممكن ممكن الاوبيس نفس الشيء. هناك عندهم مشكله بالريس ومشكله بالسوشيو ايكونوميك، يعني عندهم هم بلاك ووايت هم عندهم مشكله. يعني يجوز عندنا، يعني انت اذا تخبطين مثلا سوشيو ايكونوميك، اذا منطقه بها عرب وكراد يجوز تلعب دور مثلا. فانت ممكن اذا عندك عرب تركمان كراد وتريدين اكواليتي بيناتهم، هم لازم تاخذين نظر الاعتبار كل هذه النقاط. اكو طرق معينه هي كلها بس مو سهله مو دايركت، بس ممكن they will take care of this issue. هذا الحكي بالراندومايزيشن مثل ما قلنا. بعد عندكم سؤال، يعني هو انت حسب it's according to your research you don't but always think high. You always try to do randomization, always to do blindness if possible, always to avoid convenience sample. Because when you say my study design was convenience sample, they always pick. What's the problem in the convenience sample? What do you think? What's the main limitation? It's not just the power. Why it's a quality convenience sample? Convenience sample mean anyone I can reach, I can move it. It's the generalizable. Because for example, if I go to Facebook, I post my survey, electronic survey there. Only people who have survey, Facebook, and they like the technology. The people they like technology savvy, who can answer this. Like in the United States, if they can, for example, if they need to reach elderly people, they cannot send them an electronic survey. They send them the envelope with the paper survey in the mail, with the prepaid envelope, because they have no access. So you always cannot generalize the convenience sample, because your convenience sample, only people, highly educated people, only people from Baghdad, only people from Arasafa, only people, you cannot generalize your results, which is main issue. You cannot say this is Iraqi people, because you only measure people in one hospital in Arasafa and you say those represent Iraq. How can you say? You cannot say this, because this is not like in the United States they have something called national survey. National survey is representative. They go and they pick random sample from the neighborhoods, and eventually they have representative sample. You can choose small sample, but it's representative. So randomization always good. السلام ورحمة الله. عندكم بعد سؤال بدنا نحكي؟ أهلا وسهلا دكتور.
احنا بدنا نختار على القاعات
ها قصدك على البحث مال؟ ها